All right, good evening, everyone, and welcome to our Woo You event, Innovations in Glaucoma Drug Delivery, What the Future Holds with Dr. Justin Schweitzer. So I'm your host, Dr. Arielle Sorenzi, and I'll be moderating today. So I'd like to introduce our speaker, Dr. Justin Schweitzer. I told him I wanted to pronounce it in a German way, but I don't want to scare anybody. Schweitzer. He was born and raised in Jamestown, North Dakota, attended Pacific University for optometry school. He did his residency at Vance Thompson Vision in Sioux Falls with a focus on anterior segment disease and glaucoma. And that's where he is now, where he's the cornea, glaucoma, cataract, and refractive surgery specialist. So he gets to live and breathe glaucoma all day, every day, and anterior segment disease all day, every day, and help guide us in the best way possible. He's also the co-chief and medical director in modern optometry, and you can find him if you Google him, which I did, and all kinds of scientific posters, publications. He speaks at all of our nationwide meetings. I've had the opportunity to see him lecture at Academy myself in Orlando, and really excited to hear our talk today. So thank you so much for joining us.
Oh, thanks so much for having me. I will come back to that slide in a second, but really an honor. I've had the opportunity to do a Woo University webinar in the past, and they're always such a blast, so well done, great attendance, and just great questions. So really an honor to be here. I never take these things for granted. It's really a blessing. And I want to thank everyone that's here for taking the time out of their evening or early afternoon, depending on where you're at, after a busy day in clinic, I suspect, to spend it with me. I don't take that for granted either, because it's not easy after a busy day with probably family, friends, significant others that you could be doing other things with, to spend it with me. But I'm excited to do this lecture. And this is a interesting lecture for me, because when I think about things that I'm most excited about in the treatment of glaucoma drug delivery is right up there. And as you'll see throughout this lecture, some of this is not going to be necessarily clinically relevant, because we don't have a lot of glaucoma drug delivery devices on the market. We really only have one, but there is one on the market. And so we are able to talk about how we can implement a glaucoma drug delivery device in our practices or work with people that are utilizing them, whether it be surgeons or other optometrists. So although there'll be points in this lecture where you'll say, boy, I wish you would get past this data, this is kind of boring, I promise you there's going to be some clinically relevant pieces to it as well. I'll go back to this quick slide. I do got to disclose some financial interests, and mainly it comes with some of the different glaucoma companies that have some glaucoma drug delivery devices. So you'll see that, but we will definitely cover all of them. So you'll see very quickly that there's really not going to be any bias in regards to any of the glaucoma drug delivery devices. Now, I work in a tertiary care practice. I work alongside a glaucoma specialist. My day-to-day activities are really preparing patients, whether it be for anterior segment surgery, glaucoma surgery, cataract surgery, to undergo those procedures. But I also work a lot with our referring network, or my colleagues, optometrists, that ask for another opinion, want to know, hey, what would you do with this glaucoma patient? Send it into our practice. I take a look at it, and we have really nice discussions about it. And we've already started to utilize glaucoma drug delivery in our practice. And so I'm happy to be able to share some of that with you. This part of the lecture is going to be 50 minutes, but I'm also going to do a 30-minute promotional lecture in regards to the Allergan product that's available. And I always want to thank Allergan for sponsoring an event like this. These events couldn't happen without their types of sponsorships. So we'll have an opportunity tonight, if you want to spend about an hour and a half together, really talking about ways that we can implement and utilize drug delivery in our practices. So I'm sure many of you have patients like this. This is a very common thing in my particular practice. These types of patients come in all the time, and you could tell this patient is not comfortable. This is a glaucoma patient that doesn't take his drops like he should. He doesn't take his drops like he should because his eyes are irritated. And if there's anything that you could take home tonight, I want you to think about glaucoma not only as a visual field or a visual defect or a vision loss type of disease, because it is. And the one thing we're trying to do is prevent our patients from losing their sight, but also think of it as a quality of life disease as well. And by no means do I want to sit here and bash drops. I utilize drops every single day in my practice. They're extremely important and we need them on a consistent and daily basis. But what you're going to see with some of the studies that I kind of set up here before we get into the drug delivery devices is that some of these drops, depending on how many they're on specifically, can create quality of life issues for our patients. And if there's ways that we can decrease the burden of medications, take patients that are maybe on 2 and get them to 1, or even take some patients that are on 1 and get them to 0, we're going to improve their quality of life. Yes, ultimately, we're trying to prevent vision loss, and we don't want our patients to go blind from glaucoma. But really, the quality of life issues that these patients suffer with are just as important. And so think about that as we kind of get into talking about the different nuances of the glaucoma drug delivery and some of the studies that you're going to see here shortly. So why as optometrists should we really care about glaucoma drug delivery? Well, number one, we are going to be utilizing some of these glaucoma drug delivery devices. Right now, the one that is on the market, there's 4 states that are actually implanting it in the United States. So there are optometrists around the country that are already utilizing it. But the other reason we should care goes back to that quality of life issue. It goes back to preventing visual field progression. These things matter, as you're going to see in the next studies that we go through, because our patients, even though they're telling us they're being compliant, even though they're telling us they're utilizing their drops, they're just not doing it. And the more drops they're on, the worse their compliance is. So how do we minimize the amount of drops that they're on? So let's set the table on some of the issues that we run into when we think about our patients that have glaucoma. Number one, there's compliance. 2 studies here, the Nordstrom study there on the left, published in 2005, looking at a variety of different glaucoma drops. And it's interesting, if we look at the prostaglandins, the ones that we say, boy, our patients only have to take those 1 time a day, they're very likely utilizing these drops. I know they're taking them. You can see by 6 months, it's already 50% of them have discontinued their medication usage. That's with prostaglandins. The other medications, when they have to be utilized 2 times a day, 3 times a day, they utilize them even less. So in his study, more than 90% of the patients were non-adherent to their ocular dose regimen. And then the other study here, the Travatan dosing aid study, a fascinating study because these patients were given the medication for free. We know patients complain about the cost of medications. In this study, they said, hey, we're just going to give you the medication for free. Oh, and by the way, we're going to monitor you. We're going to make sure that you're taking your medication on a daily basis. So please do it. And 45% of the patients utilize their drops less than 75% of the time. Mind blowing. They were given it for free and they were told that they were going to be monitored. And still 45% of the patients use the drop less than 75% of the time. And so it's an issue. This term, interventional glaucoma, keep this front of mind when we start talking about the different devices, physician-driven situations. When we move to the left there, that arrow taking us to the patient with a cataract, mild to moderate glaucoma, to me, that's an easy interventional situation because in that case, we're probably going to utilize a MIGS procedure. Where it gets a bit trickier is on the right side. When we think about interventional glaucoma, physician-driven, what that really means is we're able to intervene earlier in the disease process. We're able to slow down glaucomatous progression without making quality of life issues worse. So we may have that patient that had cataract surgery, or we have that patient in the middle that has a really red, irritated eye, or the patient on the bottom that is unable to get her drops in correctly. And not only are we going to be dealing with visual field progression, but we're going to deal with corneal ulcer on top of everything else. We want to utilize physician-driven types of treatments. Unfortunately, drops aren't that, because when we think about drops, our patients have to utilize them. If they don't utilize them, they're not going to lower intraocular pressure. But when we think about drug delivery, that's physician-driven. A pellet placed inside the eye that releases medication is going to reduce the burden of medication uses. A MIGS procedure, SLT, these types of procedures are more physician-driven because we're reducing that burden of therapy on our patients. And that's really what I want you to think about as we kind of get into some of these devices. Side effect profile. Now, I talked about it. Medications can create irritation. You look at this particular study, the group in the red and the group in the blue. The group in the blue no side effects from their topical medications. Group in the red was having side effects from their topical medications. They followed these patients for an extended period of time. What you're looking at there is visual field progression over time. So in the red, the patients that had side effects, they were progressing at a much more rapid rate than the group in the blue. Now, the group in the blue progressing as well. Why? Because glaucoma is a progressive disease. We can do the best we can. We can use medications. We can recommend surgery, but unfortunately, glaucoma is progressive. But if we can decrease side effects, the data supports that very likely our patients won't progress as rapidly and it won't be nearly as aggressive. Ocular surface disease, I've kind of mentioned this multiple times, but it goes back to the more drops that a patient is on, the more likely they are to be symptomatic. The less drops, if we could decrease the burden, the less symptomatic they're on. I did a study with some colleagues of mine, Dr. Whitney Hauser, Dr. Mitch Eibach, Dr. John Burrell, where all we wanted to do was see if we could remove medications on patients that were undergoing cataract surgery plus a MIGS procedure. We had them take an OSDI, ocular surface disease index, at the beginning of the study. They underwent cataract surgery plus a MIGS procedure. We had them take it at 3 months on the end. The OSDI preoperatively was over 40, so it fell into that severe range of symptomology on the OSDI. After we got done and we checked them again at 3 months, had them take the OSDI at 3 months, it dropped all the way down to about 17, which is in the mild range, not normal, but mild. But think of how much of a quality of life improvement we made for those particular patients. Now that's focused on MIGS, but drug delivery really is going to do the exact same thing, as you'll see here in a little bit when we start looking at the different procedures and different devices. The other thing to keep in mind is a lot of the medications we use are preserved with BAK. I don't care if it's topical glaucoma medications, topical corticosteroids. We want to be aware of this. Now, BAK in small amounts can actually be very advantageous. BAK in small amounts can help medications get to the target tissue, and I'm going to talk about that here in a little bit. But this was an interesting study published in 2012 looking at patients that were normal or untreated, patients that got BSS, which is essentially sterile saline, patients that got BAK 0.01%, patients that got BAK 0.1%. And they were only dosed once a day for 7 days. And what you see in that middle image is day 0, where the corneas were nice and clear, and then day 7. And if you look at the bottom images there with the BAK, you can see that there's a lot of punctate epithelial keratitis. The cornea is very beat up versus the untreated and the sterile saline group. You look over at nerve fiber density, BAK causing damage to the corneal nerve fibers. So that's a problem. We don't want to have corneas that have decreased sensitivity. Decreased sensitivity to the cornea leads to ocular surface disease, leads to a breakdown of the corneal epithelium, leads to issues. And then on the far right, aqueous tear production reduced in the BAK groups. If we have reduced tear aqueous production, we're going to have symptomatic patients. And so again, not saying don't use glaucoma drops, just saying be judicious with them. Think about trying to keep patients on as little as possible. 1 drop ideally, 2. I know that's not always possible, but we now have procedures. We now have drug delivery, which can help us in that process. So what are the challenges with topical drug delivery? Not talking about inside the eye, not talking about glaucoma drug delivery yet, but topical drug delivery. Well, our eye does a beautiful job of keeping things out. It does a wonderful job of not allowing things to get where they shouldn't be. And we want that. Otherwise, we'd have tons of different corneal infections, and we already deal with enough of that. But the eye does a beautiful job of not allowing that to happen. The other thing is the nasolacrimal duct system, our tear film, basal tears, reflux tears do a heck of a job of not allowing medications to get where they need to get. And I credit the pharmaceutical companies in producing great medications that get to target tissues quite often, because if you look at this stat here, the amount of medication that's on the ocular surface only has less than 5 minutes to get where it's supposed to go because of all these things that are trying to wash it out or get rid of it. And so they've come up with solutions with the way that they deliver it, but there still remains challenges. Really only about 5% of the dose reaches the target tissue because of the things that I just mentioned. The cornea will absorb it, the conjunctiva and the sclera will absorb it. It's not able to penetrate. And so how do we get around that? What do we do? What are our different solutions to that? This really is what drives the discussion on drug delivery in general, and specifically tonight when we're talking about glaucoma drug delivery. So these are all the different devices, procedures, that we're going to talk about tonight. And again, there's only one of these that's FDA approved. So hang in there with me when we're going to get into the data in a little bit. But all of these other ones are being looked at and possibly going to come to market in probably a lot of our careers. I would say, in the next 5 to 10 years, a lot of these will probably be on the market and we'll be utilizing that. Optometry will play a major role in utilizing a lot of these different glaucoma drug delivery devices. But you can see here, we have injectable systems. We have systems that need to be implanted into the trabecular meshwork. There's contact lens devices. There's microdose sprays, anapheresis, which we'll touch on as well. There's punctal plug delivery devices, something that a lot of us utilize to treat ocular surface disease, and then a ring that possibly may be available as well. So when I think about kind of the glaucoma treatment flow chart, this is kind of the way I look at it. We have our conservative therapy. Some of our patients we monitor. Ocular hypertensive patients, we don't always treat those patients. We're monitoring them. That's very conservative, obviously. We have our glaucoma medications, and now SLT to me is a very first-line therapy. Those are very conservative treatment options. Drug delivery probably is going to fall in between there. Some of the glaucoma drug delivery devices are excellent from a safety profile. We really don't have to worry about issues with them. Some of them, because they're inside the eye procedures, may carry a little bit more of a risk. And then we have our surgical procedures. Cataract surgery alone lowers intraocular pressure. We know that cataract surgery paired with MIGS procedures or minimally invasive glaucoma procedures lowers pressure. And then we get to those more aggressive procedures, which we're trying to avoid. We don't want to get to tube shunts. We don't want to get to trabs, because although those lower pressures effectively, they come with a lot of side effects that we really don't want to deal with in our patients. So the goal is, how do we keep them more on that left side, not allow them to get to more advanced glaucoma, keep them that mild to moderate range so that we can continue to manage them. One thing that's going to be really important when you talk to your patients about glaucoma drug delivery is how you educate them and the wordings that you use. This was a study of 199 patients. It was a survey that was done looking at patients' attitudes towards different glaucoma treatment options. This was published, as you can see, in 2018. They asked these patients about eye drops. They asked them about a microdose spray. They asked them about injectable procedures. And what's interesting, when they started to use the word, or the word that was on the survey, of injections or injectables, the percentage of acceptance went down. Now, patients that had filtering surgeries or more aggressive glaucoma procedures were more apt to say, I would do an injectable procedure. Patients that had not had glaucoma procedures, that were maybe on topical glaucoma medications, were less apt to do injectable procedures. And so when we talk about these devices, specifically when I talk about latanoprost SR, which is the FDA approved one, I don't ever use the word injectable. I say surgeon's going to place this inside the eye. And there's optometrists doing it in 4 states. Like I said, I like to use the word place it, not misleading the patient, because when you look at the clinical trial data on that particular implant, there were 0 cases of endophthalmitis in the phase 3. We've probably done 135 or so of them, and we've had 0 cases of endophthalmitis. So it's a safe procedure once you learn how to do it. And so I don't think I'm misleading patients by not using the word injectable, because the attitude is everything. The way we educate is everything. And so we want to be careful in the way that we talk to our patients about this, because these things can change the way that they're treated, and it can change their lives. So let's get into the different procedures. And again, this one is not FDA approved, but being looked at. This is a microdose latanoprost. You can see the device there. The patient holds it up, and there's a small amount, or a microdose of latanoprost, that's placed on the surface of the eye. Small amount of medication is needed in this particular procedure, 75% less of the drug and preservative, so it's going to be better tolerated. 88% of the time in their phase 2 clinical trial got to the target, and beautiful to see that we see a 29% IOP lowering from baseline, approaching what we want from our prostaglandin analogs. We shoot for that 25 to 30% usually with a prostaglandin analog, and this really in their phase 2 clinical trial showing that. Punctal plug delivery systems. There's a company out there looking at both a latanoprost and a Travoprost design. They have 2 different studies, subjects of 92 and 87. The good thing about those particular studies, the retention rate is high, meaning that once the device was placed, it didn't fall out. When you look at the clinical trial data on this, about a 5.5 millimeter of mercury IOP lowering over 12 weeks. And one thing I want to point out, when you look at these devices that are done externally, they don't seem to be quite as effective as the things that are put inside the eye. Why? Because of all the things I talked about earlier, the eye doing a beautiful job of not allowing things to get where they're supposed to go. And so you're going to see with this particular device, and in the next one we talk about, that maybe the IOP lowering is a little less than what you expected or want. Doesn't mean that they don't serve a purpose. Remember, if we can utilize something like this along with maybe an adjunct topical therapy, that's still a win for our patients because they'd only be on one drop. This getting us some IOP lowering, and that topical drop getting them some IOP lowering. So this is meant to last about 3 months. Again, not FDA approved, being looked at right now. Lasts about 3 months. It would be then removed, and then another one would be placed. Another implant. This is an intracanalicular insert. Some of you may already be familiar with the technology that's out there for cataract surgery and have placed some of these. Again, kind of like a punctal plug that many of you are used to. It's bioresorbable, so this one does not need to be removed. The goal would be that it will release medication for about 3 months. It will dissolve, and then because you're able to visualize it, it has fluorescein in it, so you'll be able to see if it's there or not there. You'll be able to place another one of these. It is preservative-free. Placing these does take a little bit of work. I've had some experience, not necessarily placing this one, but placing the one that's FDA approved for cataract surgery. And one thing that it does, and why it doesn't fall out ever, is once it gets wet, once it touches the tear film, it begins to kind of expand. And so what you really need to do is you want to dilate the punctum. You want to be ready to put it in. As soon as you put it in, it will start to dilate. And so this is releasing medication, again, hopefully for over a 3-month period. When we look at the data around it right now, a phase 3 clinical trial has been done, and unfortunately, it didn't meet its primary endpoint. So when we look at this compared against timolol, not shown to be superior to timolol, about as effective as timolol, but it did fall short over its 12-week period. And so I think it'll be a while before we see this particular one, but this would be something, again, that in optometry, this would be something right in our wheelhouse, something that we're all utilizing at this point in time anyways to treat ocular surface disease. Again, not FDA approved, so I want to repeat that, but something that will hopefully be coming at some point in time. This just gives you an image or a view of it with the cobalt blue light, how you can visualize it. It'll kind of light up. And then once it doesn't light up anymore, you know that it will have dissolved. And obviously you're going to be watching their pressure, their OCT, their visual field over this time period as well. Contact lenses. Contact lenses have been looked at for a long time. Why? Because they're an attractive option because they sit on the eye for an extended period of time. It allows the medication then to be absorbed over an extended period of time, and that can make it very efficacious. But there's been some challenges with contact lenses for a variety of reasons. Number one, again, the patient has to wear it. If they don't put it on, it's not going to be useful. There's got to be vision in the lenses. We got to have power because not all our patients are emmetropic. They got to have vision, so we got to have power in there. Dry eye ocular surface disease issues. A lot of our patients with glaucoma are a bit older, and so they suffer from ocular surface disease types of issues, and then the replacement schedule with it as well. A couple companies out there working on some drug-eluting contact lenses. This particular company already using approved contact lens and using this vitamin E nanobarriers to extend the drug release. There's some phase 1 data out there where subjects wore the contact lenses for 2 days. They then removed the contact lens, and IOP reduction was noted for 9 days. And I think that's important to note. It wasn't that the patient had to wear the contact lens for 9 days to get IOP lowering. They only had to wear it for 2 days, and then they got extended IOP lowering. If these contact lenses could be something where you'd only have to wear it for 2 days or 3 days, and then you could get a month of IOP lowering, I think it could be very, very effective. Or maybe even they wear it for 2 days and they can get 2 weeks of IOP lowering, and then they have to put another one in. I think there's an opportunity here to be utilized in our practice. Again, nothing FDA approved at this point in time. Another company looking at a latanoprost drug-eluting contact lens, a very small study of phase 1, so looking really at safety only. But what they found out in this phase 1 clinical trial is the contact was very tolerable, but there was also IOP efficacy noticed as well. So the patient wore it for 7 days continuously. It did lower intraocular pressure, and it was well tolerated. Right now, a phase 2B, or Site 2 is the name of the study, is underway, looking at dose ranging. So they're trying to figure out what's the appropriate dose to lower intraocular pressure for patients and what's the ideal dose to get the most IOP lowered without creating a bunch of side effects with it. So this is the FDA approved one. And so I want to spend a little bit of time on this because this is something that maybe some of you have seen. This is one that we've been utilizing in our practice at this point in time. It's called Bimatoprost SR. The 10 microgram group is the one we're going to focus on tonight because Bimatoprost SR is FDA approved at this point in time. It is a biodegradable implant. It is placed inside the eye, and we'll touch on that a little bit more. It's FDA approved to reduce IOP in patients with open angle glaucoma or ocular hypertension. Right now, it's FDA approved to only be done one time, and there are phase 1, 2, and 3 clinical trials. We're going to focus on the phase 1 and 2 clinical trial for this particular lecture. I am going to mention that at the end, I'm going to be giving a 30-minute more promotional talk where I'm going to dive into the phase 3. So if you're interested in learning a lot more about this particular implant, we'll cover some additional things later on. No requirement to stay to get your COPE credit, but it is something I'm going to spend about 30 minutes talking about some other tidbits around this particular technology. So if you're more interested in how you can implement it in your practice, the referral process, those types of things, I'm going to touch on that later. So stick around if you'd like to. So this is what it looks at like inside the eye. A couple things to point out. It will dissolve over time. It elutes medication for 4 months. Okay, so keep that in mind. It elutes medication for just 4 months. But we're going to talk about the phase 1 and 2, which gave us some very interesting data around it, that it may lower IOP longer than that. When it's inside the eye like this, it actually a lot of times will kind of ball up and it gets very sticky. So once it's injected, it has these pores where the aqueous kind of penetrates to the core. It releases the medication. It'll kind of turn around and it'll stick in the inferior angle. And you'll see an injection here in a second. I'm going to show you a video of us doing it at our practice. So once it's inside the eye, it really does not move around a lot. That's the nice thing about it. Once it's placed, it's not going to bounce around. It gets very sticky and it kind of stays in place. Again, I'll repeat, it's eluting medication for about 4 months. So I'm going to show you a video. What you do to prepare a patient for this is first they get a betadine wash. The beauty of this procedure is it's done with the slit lamp. This does not need to be done in the operating room, doesn't need to be done in the small procedures room. It can be done at the slit lamp. Patient gets a betadine wash. So we make sure that it's sterile in that regard. They get a couple drops of proparacaine. Typically, they're going to like you a lot better if you do that. It makes the procedure a lot easier to do. And then you'll see the surgeon in this particular situation, they always enter from the temporal side. You'll see in this patient, the pupil is dilated. My advice would be don't do it in a dilated pupil. It should be done in undilated situations. In this case, my surgeon's very comfortable with, has done so many cases that we weren't concerned about that. And we'll go ahead and play the video here. And so what you're going to see again, patients had a betadine wash. They have a drop of proparacaine placed. He's going to go in from the temporal side here. He's going to go in about 2 bevel lengths. That's about how far in you have to go. You don't have to go any farther than that to place this. And then he'll push this button, the actuator button. You're going to see it come out of there pretty quickly. You watch closely and right about now, there it goes. And it'll drop right down inferiorly. You can see it kind of settle down to the inferior angle there. Again, the patient just needs to have an open angle. We don't want to do this in patients that have any corneal disease. It'll settle down in there, and then it begins to elute medication. Why I want to bring up the phase 1 and 2 clinical trial is because this is how we're utilizing it in clinical practice right now. In this particular study, there were 75 subjects. One got the Bimatoprost pellet, one got topical Bimatoprost. We're going to focus on the 10 microgram group because that's the one that's FDA approved. An interesting tidbit about 10 micrograms, that's exactly 1 drop of Bimatoprost. That's it. So 1 drop is all that's in that particular pellet. It's releasing the medication again for 4 months. When they followed these patients, they followed them out to 2 years. When they looked at IOP reduction in the 10 microgram group, patients got about a 7.3 mean IOP reduction. When you look at the top of the Bimatoprost group, they got about 8.2. So pretty comparable. In the phase 3 clinical trial, which I'm going to talk about later in the last half hour, patients got about a 33% reduction in one study, a 32% reduction in IOP in the other study, fitting with exactly what we want to see with the prostaglandin analog. The most interesting thing that came out of this particular study was the rescues or the retreatment rates. So I mentioned earlier that with this particular implant, it releases medication for about 4 months. But 66% of patients got 6 months of IOP lowering where they did not need to be rescued. 33% or a third of the patients got a year where they didn't need to be rescued. And then almost a quarter of the patients in the clinical trial with this 10 microgram group went about 2 years without needing to be rescued, meaning that one pellet at times lowered intraocular pressure and held it there longer than what the drug was being eluted. So what does that mean? I don't know. We could theorize a lot of different things with it. One theory could be, is it remodeling the trabecular meshwork a bit? Again, I don't know that for sure. There's some small animal studies out there that have looked at that. But what we do know is that now that we've got experience with this in clinical practice, you'll hear other doctors talking about this, that some are seeing 40% of their patients going 1 year without needing to be retreated, meaning the IOP is staying down. Ours, in my practice, I would say is probably around 35% or so, but we're talking about actually going back and looking at that, doing a retrospective study to find out if that's true or if I'm just kind of off. I'm just telling you my clinical experience in that regard. I've heard as high as 60% out to 1 year from other doctors around the country. The point being that even though it's only eluting medication for 4 months, there's an opportunity here to help our patients maybe get a break from drops and we can manage their ocular surface. Or can we reduce their drops for an extended period of time? Maybe take a patient that's on 2 drops, get them to 1, maybe one that's on 3, get them to 2, because this can be utilized across all gamuts of glaucoma. It can be utilized in ocular hypertension, mild, moderate, even severe. So I think there's an opportunity here to help our patients in a variety of different ways. The phase 3, which I'll touch on a little bit later, when you look at side effects from this, about 27% of patients on day 1 and 2 really had conjunctival hyperemia. 10%, 2 days and beyond, had some hyperemia. And that's really because of the administration. When you do a betadine wash and you do an injection, the eye's going to get red. Well, that has to be reported. So the conjunctival hyperemia rates, 27% in those first days, and then post 2 days administration, it really dropped down. 5% of the patients did have some endothelial cell loss over 20 months in the phase 3 clinical trial. The phase 3 clinical trial was large, over 700 patients in it. And so about 5% having some endothelial cell loss at about 20 months, and then about 5% having iritis. In my experience thus far, about a year and a half or so, we've had one case where we've had an iritis where we've had to remove one. We've only had to remove one. Otherwise, we've really had no side effects. It's been a really fun thing to implement in our practice for a variety of reasons. I think the number one patient type that I've loved this in are my patients that are suffering from some ocular surface disease. It's meant to lower IOP, but if I'm able to take a patient that's on 2 drops or even 1 drop and just reduce that and then treat or attack the ocular surface, I'm making their lives a lot better. And I know glaucoma is a marathon, so I educate my patients on that. I let them know, hey, this is not a fix for your glaucoma long-term, but if we can give you a break for a year or even 6 months, and I can treat your ocular surface, get it healthier, get it happier, you're going to be happier. And then we can go back to some therapy. Maybe we do SLT. Maybe we go to a BAK-free drop. Maybe we move to surgery. But remember, glaucoma is a marathon. All the different treatment options we use are going to be utilized throughout the lives of a lot of our glaucoma patients. And so there's an niche for this. There's a place for it that it can work to help our patients. This is a device not FDA approved, but another intracameral implant, something that's placed inside the eye, bioresorbable again, sustained release. It goes into the anterior chamber. It's using Travoprost, so different than the one that we talked about before. And the target here is 4 to 6 months. They have done studies in animals. So there's beagle dog studies showing that this is effective 4 months or longer. IOP lowering in those particular studies was about 25 to 30%. Again, meeting what we're hoping for with prostaglandin analogs. If we can get that 25 to 30% reduction, we're pretty happy with that. That's what we want for a first line agent. This is their phase 1 clinical trial in a very small cohort. Again, remember, phase 1 is just really looking at safety. When we look at this, you get really effective IOP lowering in all cohorts, at day 28, really at that 1 month. And why you see the end values, so at month 4 going to 4, at month 6 going to 3, the subjects dropping, is because when they had to rescue the patient, when they had to give them a medication, then they were removed from the analysis. And so we're seeing some IOP lowering in some patients out to 21 months, out to 9 months, out to 6 months. And so again, overperforming than what we expect. Now, again, a very small study. You can see the cohorts are 5, 4, and 4, but still nice to see that we have some IOP lowering longer than what we'd expect with a device like this. There is another device that is being looked at right now. This particular device, this print technology, is being utilized more for a retina, and it's being studied, but it also has been looked at for glaucoma drug delivery. This is implantable again. It's an extended release implant that will release Travoprost over time. There is a study out there, a small study, only 11 subjects in this study. But what they looked at were patients that were on Lumigan or they were on Xalatan. These patients were well controlled or fairly well controlled at 19.7 was their intraocular pressure. They stopped the medication. They washed them off it. The pressure went up to 26. This device was placed inside their eye. And what you see is about a 25% reduction, which is essentially what the pressure was when they were on the Lumigan or Xalatan, giving us hope that this type of device will get us as effective as the Lumigan or the Xalatan. Another device not FDA approved, again, I want to say that, but this is a Travoprost intraocular implant. Now, this is going to have to be done in the operating room most likely. This is a device that's actually a small clear corneal incision is made. The device is implanted into the trabecular meshwork, and then the medication is eluted through this particular area right here that I'm circling on the device. So it anchors in the trabecular meshwork. It's a little larger device. It is important that the surgeon places it above or in the superior temporal, superior nasal quadrant, because we want the eyelid to kind of hang over the top of it, because it could be seen. It's a larger device than the ones that we're talking about right now. You can see it here on gonioscopy. This is a view there in that bottom left. And then here you can see I've lifted the upper lid in this particular patient, and you can see the device here in that kind of superior nasal quadrant. It's going to be releasing that medication. The goal with this would be that it will lower intraocular pressure at least out to a year, maybe 2 years, maybe even 3 years. I'm going to show you data on that here in a second. I'm not just stating that. There's actually data supporting that this may lower pressure for an extended period of time. And then what would need to happen is the device would need to be removed and another one would be placed as intraocular pressure went up or patients began to progress. So this is their phase 2 data, and they have 2 arms in this particular study. They have a fast elution group, and then they have a slow elution group. So they're looking at both of these. It's compared against timolol. What we saw at a year in this particular clinical trial, so at 12 months, we saw about a 32 to 33% reduction in intraocular pressure, really in both implant groups. Well tolerated, good IOP lowering. There has been since updated 2-year data, 24-month data with these particular patient bases. Average IOP lowering about 7.9 and 7.4, respectively, in the fast and slow elution group. And then you can see again about a 29% to 28% reduction in intraocular pressure in both groups. So at 2 years, still seeing effective IOP lowering at a level that we really want to see in our patients if we think about what we do traditionally with prostaglandin types of therapies. There now is even 36-month updated data showing an average IOP reduction of about 8.3 and 8.5 in the fast and slow release arm groups. And so again, a lot of patients, 70% and 68% of these patients not needing to be or on fewer medications than when they started. So reducing that burden. You can see the surgical procedure being done here through a clear corneal incision, intraoperative gonioscopy mirror placed in the trabecular meshwork. And then that will release medication over time. Couple other things, hang in there with me. We're pounding through the data. We'll get to some more discussion here in a second. But anaphoresis, I think this is interesting because right now, this has generated a lot of buzz to manage uveitis or irises. Some studies being done with dexamethasone. And really what anaphoresis is going to do is it pushes a lot of medication to the target tissue by using an electrical field or an electrical charge. And that's advantageous because you're bypassing all those things that we talked about earlier. We're bypassing the tear film, which is washing away medication. We're bypassing the conjunctiva. This is just using that electrical current to really force the drug to where it needs to go. How can it be used in glaucoma? Well, if we can find the right dosage of a glaucoma medication that can be placed into the eye, and you can use higher dosages that will last for an extended period of time, maybe this is a situation where our patients can come in every so often to the clinic. They would be hooked up to this particular device, and then eventually that medication would be put into their eye very quickly, and it would last for an extended period of time. Again, more useful right now in uveitis and iritis, because those conditions typically, not always, but typically are not chronic in nature. With glaucoma being more chronic in nature, would this be something at some point in time that could be designed where it could be sent home with a patient so that they could do it at home? Not there yet, but still an interesting thought with this. Could this be something that could be at-home therapy? Refractive capsule. So this is something you may have read about. This is interesting because this can house an IOL. So the patient's cataract is taken out. This is put inside the eye. There can be IOP sensors that are placed in this. There can be drug delivery devices that are placed in this. And I will comment that the future of measuring intraocular pressure is probably going to be sensors that are placed either on IOLs that are done inside the eye, where we can get instant IOP data on our patients that can be shot right to our phones, that can be placed on the computer, those types of situations where we're always going to know what our patient's intraocular pressure is. They may not specifically know, and we prefer they don't know because we don't want to get calls at midnight, 1 a.m. when they're 2 above target, but we'll know and we'll be able to manage our patients better. And so this particular capsule actually can be placed, cataracts removed, placed inside the eye, and it can house different types of units. So I want to have a little conversation on what do we consider first-line glaucoma therapy. I would say in my practice, it still is topical medications. Patients typically will choose that. And I really talk to my patients now about 3 different things when I talk about first-line therapy when they're newly diagnosed. I talk about drops, and that's going to be prostaglandin analogs. We have some great prostaglandin analogs out there that are well tolerated, that lower intraocular pressure. I talk about SLT. And it's interesting, when we ask doctors in our network and our referral network, we say, well, what would you do for your eye? Would you have a drop? Would you have SLT, or would you have a drug delivery? Which is the third thing now that we really should talk about as first-line therapy, because we have one on the market. 70% of the doctors, when we survey them, and we've done this at education symposiums, will say, boy, I'd rather have SLT. But then we ask them, how many of your patients choose to do SLT? And it's flip-flop. It's probably about 70% of their patients choose to do medications, 30% choose to do SLT. So that begs the question, is it the way that we are educating our patients? Because we would rather have SLT, our patients lean towards medications. And I do think that either one is an option now. I think SLT, there's been new data. Many of you have heard of the LIGHT study, which I placed in front of you here, that has said that SLT is a very effective first-line agent for patients. Again, I think we have great drops as well. And I let the patient drive the bus a little bit on this when I talk to them about their options. I mentioned SLT, I mentioned drops, then I mentioned drug delivery. When we look at the LIGHT study, really the primary outcome was to look at quality of life. But what we got out of the secondary outcomes was its clinical effectiveness, the cost of it, the safety of it. And most importantly, we got how long it lasted. And so when we look at the conclusions here, the biggest take home for me, which it's not even on here, is that 78% of patients were drop free at 3 years. That's a big number. Remember that number. 78% of patients were drop free at 3 years. And you have the other conclusions here too, which show, number one, that medications are effective. 91% of patients still hit their target pressure on medications, 93% for the SLT. But 78% of the patients were drop free at 3 years with SLT. And again, glaucoma is a marathon. We're going to need to utilize all these different therapies over time. For example, if you want to use that drug delivery device that we talked about earlier by Microdose SR, you can do that before you do an SLT. Or if a patient's had a previous SLT and you want to keep them off of drops, that's something you can place. In their phase 3 clinical trial, patients, 6% or so, had previous SLT, and it still was very effective. You're eventually probably going to have to go to a drop anyways. And so think about first-line therapy. Think of these 3 things as options. Educate your patients on it. Discuss it with them. What about insurance coverage with glaucoma drug delivery? Well, again, we only have one that we can really talk about right now because there's only one on the market. And that particular one, if it's a Medicare type of patient, is pretty well covered right now. Commercial, pretty well covered as well, a little bit different. But insurance will drive this as well. Hopefully, as we get more of these glaucoma drug delivery devices, the groundwork will be laid to get a lot of these covered so we don't have to fight with getting them covered for our patients. We know that SLT is very well covered. We know that a lot of our topical glaucoma medications at times can be very well covered as well. I credit pharmaceutical companies for helping us in that regard to provide payment programs, to provide coupon programs for our patients so we can get them the therapies that we want. And then a big piece of this is going to be collaborative care. We're going to have to work with our ophthalmology colleagues in regards to a lot of these glaucoma drug delivery devices. Some of them, yes, we're going to be able to do. As I mentioned earlier, 4 states already optometrists are doing latanoprost SR. But we need to work with surgeons that are willing to work with us. And I would urge you to seek out surgeons that are doing these procedures. Seek out surgeons that are doing multiple MIGS procedures. Seek out surgeons that are doing this latanoprost SR if you want to get involved with it, and then have a discussion with them. Have a conversation with them that says, hey, I'd love to continue to take care of this patient. They're your patient. You're sending them to them. And if they're not willing to work with you, then that's a situation where you seek out a surgeon that is. Because I could tell you, I've been all over the country. I've done lectures at ophthalmology practices. I've talked to ophthalmologists. I work alongside them. And there's plenty of ophthalmologists out there that want to work alongside optometry. They believe in our mission as well. They know that when you think of glaucoma, the numbers are only increasing. We look at, the numbers. You think about the year 2030, there's going to be 4 million Americans with glaucoma. By the year 2060, there's going to be, there's going to be around, so 2050, there's going to be over 6 million Americans with glaucoma. And so the sheer number of glaucoma patients, there's no way ophthalmology can handle the care by themselves. There's no way we can. So we have to get involved in managing these types of patients. We have to be involved in the care. We have to be involved in watching for progression. And then we have to be involved in the collaborative care of when it's right to make that referral to intervene earlier in the disease process, whether that be with, drug delivery or whether that be with MIGS procedures as well. So really, in conclusion, this lecture was not about getting rid of drops. That's not the goal. I don't want us to say, boy, we don't want to use drops anymore. We have effective drops. I utilize them every single day. What I really want this take home to be is, remember, the field loss, the loss of vision for our patients matters. But I would argue that the quality of life issues in glaucoma are just as big of a problem as the loss of vision for a lot of our glaucoma patients, because a patient that has mild glaucoma and has a small visual field defect, or a patient that has mild glaucoma that has no visual field defect but has OCT thinning, they're not going to know that they have the disease. They're not going to care about that. What they're going to care about is the fact that they're on 2 or 3 drops and it's creating issues with their eyes. So those quality of life issues matter. And so don't think about getting necessarily rid of drops. We want to think about, how do we reduce the medication burden for our patients? How do we make their lives better so that they don't have to worry as much about taking their drops? Think of the Nordstrom study. Think of the other studies that we talked about. And finally, in conclusion, think of glaucoma like a puzzle. There's a lot of pieces to the puzzle. Let's not get caught up in just thinking of glaucoma as an IOP disease. We have all these things on the left side there. We have corneal thickness. We know from the OATS study that corneal thickness is a risk factor for our patients with ocular hypertension. Patients that have corneas that are on the thinner side, less than 555, are at risk if they have ocular hypertension for glaucoma. We think about visual fields. We need to utilize those. We need to make sure we're dilating our patients, taking a very close look at the optic nerve head, making sure that we're looking for optic neuropathies. Corneal hysteresis, a measurement that I think is very helpful in assessing risk of progression, in assessing risk of conversion. And there's plenty of data supporting that. Low corneal hysteresis being that problem. IOP matters. We know that. That's what we treat. And then the family history. And then you move over to the right side. A lot of different therapies available. We've talked to a bunch of these: SLT, MIGS, filtration procedures, glaucoma medications, but drug delivery now fits into that puzzle. Drug delivery is something that we can utilize to manage our glaucoma patients. And so as I leave you today, we're going to take questions here after this, but as I leave you, think of glaucoma like a puzzle. Utilize all those different puzzle pieces, put them together, diagnose glaucoma, at a high level, and then think about all your treatment options and have a discussion with your patient about them. We have an oath. We all took it to talk about all the different treatment options that are available to our patients. And right now, what we have to talk about is we have to talk about all those on the right side, because we have FDA approved devices. We have FDA approved MIGS. We have FDA approved, obviously, SLT, and we have FDA approved glaucoma medications.